လို့ရပြီနော်အားလုံးပဲမင်္ဂလာအခု session ကတော့68ကြိမ်မြောက်မြန်မာနိုင်ငံဆရာဝန်ကြီးလာခံရဲ့ clinical session medicine portion ဖြစ်ပါတယ်ဒီနေ့အခမ်းအနားမှာကျမတို့စိတ်ဝင်စားစရာ case 6ခုကို present လုပ်ပါမယ်စစ်တပ်ကသိုလ်2အင်းစိန်ဆေးရုံကတယောက်ရန်ကုန်ပြည်သူ့ဆေးရုံကြီးစစ်တပ်ကသိုလ်1 renal unit ကတယောက်နောက်ပြီးတော့တပ်မတော်စစ်တပ်ကသိုလ်ကတစ်ခုနောက်တော့ YGH Ward 4ကတစ်ခု GM Ward ကတစ်ခုနဲ့ရန်ကုန်ပြည်သူ့ဆေးရုံကြီးစစ်တပ်ကသိုလ်1 cardiac medical unit ကတစ်ခုဖြစ်ပါတယ်အဲ့တော့ case 3ခုကိုကျမပါမောက္ခဒေါ်မကြီးကခေါ်ပြီးတော့ကျန်တဲ့ case 3ခုကိုတော့ဆရာမဒေါက်ခင်ဖြူပြပြောပါမယ်ဒါနဲ့နောက်တစ်ခုအရေးကြီးတဲ့ announcement တစ်ခုလည်းပြောပါမယ်ဒီ medicine ပြီးလို့ရှိရင် OG session မှာပြီးလို့ရှိရင် pediatric session မှာ pediatric session ရဲ့အဆုံးမှာ68ကြိမ်မြောက်မြန်မာနိုင်ငံဆရာဝန်ကြီးညီလာခံရဲ့နော် best paper နဲ့ poster တွေ award ပေါ့နော်စုပေးပွဲအခမ်းအနားကိုလည်းကြီးညာပြီးတော့ထုတ်လွှင့်စရာရှိတဲ့အတွက်ကြောင့်မလို့စိတ်ပါဝင်စားသူများနဲ့ဖြစ်နိုင်လို့ရှိရင်ဆက်နေပြီးတော့ဒီစုပေးတာကိုအားပေးကြပါအဲ့ဒါပြီးလို့ရှိရင် academic committee ဥက္ကဋ္ဌဖြစ်တဲ့ပါမောက္ခဆရာဦးရေးမောင်ဟန်ပိတ်ပွဲကျင်းပပါမယ်အခမ်းအနားပိတ်တာလည်းသိမကြောက်ဘူးဖြစ်တဲ့အတွက်ကြောင့်အားပေးကြပါလို့ပြောချင်ပါတယ်အခု clinical session ကို medicine ကိုစမှာဖြစ်ပါတယ်အဲ့ဒါမှမလို့ပထမ case နဲ့စစ်တပ်ကသိုလ်2အင်းစိန်ပြည်သူ့ဆေးရုံကြီးက case ပေါ့နော် loss of hope but not all ဆိုတဲ့ case ကို present လုပ်ဖို့တဲ့နော်ပွဲလွန်ကျောင်းသူဒေါက်တာဇွန်နှင်းဝေဦးကိုဖိတ်ခေါ်ပါတယ်
Okay. Our presentation about the last hope but not all case. 35 years old pregnant lady without previous medical or surgical disease was admitted to Insane General Hospital on 6 November 2020 with a chief complaint of fever for 3 days and loss of smell for 1 day. She was in her 27-week gestation. Fever is low-grade, continuous in nature with no special time of occurrence. It was only associated with loss of smell and her husband is said to be COVID positive. So RDD of COVID was taken as insane fever clinics and was positive. Thus, she was admitted to isolation ward of Insane General Hospital. On admission, she was febrile, temperature is 100.6 degrees Fahrenheit with unremarkable respiratory examination findings. Her abdomen is distended with uterus size for 26-week gestation and fetal heart sound is present. On admission, her vital sign was stable. Thus, case summary. 25 years old G1B0 with 27-week gestation, presenting with 3-day duration of low-grade continuous fever without chest and rigor, followed by anosmia and subsequent COVID RDD is positive. On examination, patient is febrile and hemodynamically stable. Thus, our professional diagnosis is COVID-19 infection, FDA and G1B0 elderly primary gravidia with 27-week gestation. Although on admission, she is clinically stable, but second day admission, can bleeding occurs spontaneously, followed by the bleeding by vagina. Thereafter, bruise over the upper limbs and lower limbs is noticed. At the time, she began dyspnea, temperature is still high, gum bleeding and bruises over upper limb and lower limbs is noticed. Examined, there is a blood oozing from the veni-ventral side. Her blood pulse rate began increase up to the 130 per minute with small volumes. Blood pressure dropped to 86-60 millimeter mercury. Thus, due to her bleeding manifestation, we suspect the DIC. So we have done the CBC. According to CBC result, there is a normochromic normocytic anemia with thrombocytopenia. Thus, according to the blood report, there is a fragmented RBC and thrombocytopenia. Thus, to improve the hemolysis, we have done the LDH and radicals. There is an increased LDH and radicals. So we have done the DIC screening. The results are prolonged PT-APTT result and highly elevated D-dimer with reduced fibrinogen level. Thus, all findings are indicated suggestive of DIC. So we have to exclude the DIC. Due to the pregnancy, black sac HELLP syndrome. So we have done the urea creatinine electrolyte, liver function test, and uric acid. All are within normal limits. So our final diagnosis was COVID-19 infection complicated with DIC. GMP0 elderly primary gravidator in 27 week gestation. The patients are in shock state, so we have provided the state shock with fluid challenge and IV inotrope. And we also added the IV CVP and dexamethasone, fresh frozen plasma, and PRP. That's during critical condition. She started to present with premature liver pain, followed by the premature membrane rupture. At that time, fetal heart sound was absent. Unfortunately, male stable baby was delivered. No maternal complication during intrapartum and postpartum period. From 6-day admission after deliveries, bleeding manifestation was gradually resolved, temperature test to normal, and vital sign began stable. Patient condition gradually improved clinically and biochemically. Patient was DC on 18 November 2020. That's only pregnancy cat 1 in never cat in never latte. So we met the Jarema second admission of Sasula, the DNC when I got a pregnancy mouth, DNC Lottie Susuya to the land of vision, unfortunately. So I don't baby was lost at our pregnancy general in the DNC when that is to your baby lost it as a paper Shajiakama. Tomorrow things so many people tomorrow. Pregnancy period of COVID when the Susuya dictated as well. Data is shut out to Yare. Preterm baby or PPR and all, publishing data solution, maternity by an pregnancy in that COVID, Tika and Lalation of coagulopathy, coagulopathy must presentation and immune in a general case, TNC will not so dare. COVID coagulopathy, Tika Lalation or leaving a ladder as we rob your Tika macro angiopathy in it. I'm going to cytokine strong in a ladder, and if phospholin in a ladder, TNC in a ladder. General case car DNC in Lara, so DNC will knowledge of prognosis in the bloody solar such a general case car Gango Thomas of attaching away DNC rate association or survivor rate at all you need to out to Shigeare. I don't know general case in the present law still no come comes at him Kaliro Petavati Petake, general patient law suffice Dr. Torres of the pregnancy in the pathology, COVID era. COVID infection will lose maternal fetal organ water, so that is all he gets like the okay, pregnant women can lose in Tika Bobby of few sites in a month and then a line of Tika COVID such a solution, no, they are closely monitoring the case of the case can be off. That began as well, which I can. I feel me item.
Tu can cloak time at your semi baby slightly short high. A very case to your discussion questions on a coup, audience in it. Chat net you any marometriba, Mimi and Jinamia Shibala. Take out our participant at Toang as an Ayashibari. Error to our loss of hope, but not at all. So to be original, yes, so are a clinical complication to Pidware, or Lonchara DIC bono. Now to Kuale, who teach our Luna, Telegy, elderly primary gravida, not to Ali to get very precious baby boy, and losing a clear. Let's say Chapa lost with our Rosura of Pidware, no, but not at all, so are a manjida do. At that is only job of Jibu. You know what teacher are clearly master in Lake, we got them so that the social Mishibu was only Malay through Bono, viral transfer of Mishibu, so one people so we the get the case are tomorrow say you the gas so what it up at Amazon. Lesson in Langaro, pregnancy in a COVID illusion or Yamelonero, Babin in Ibono, which tomorrow way we got them at Hammer, Leviaro, Hotel and Pune, say una Timulu, that tomorrow you like the thing and Savono. Dali will share up your body. Migumia, Mara chat, my big to cook tree and chile. Okay, the yellow Migum she may am choosing. My second presenter, Kawame, around Dr. with you, Barry, young people say on Urina Unicawa to a case of diabetes with diabetic nephropathy with Mafi. Interesting case, Bar. Dr. with you, please.
We are my Jesus de Mare, Amaro, Daniel, Jesus de Mare. My Piogonia Dele 1 hour.
Yeah, 7 minutes, Yame. She minute join a minute discussion, be me. 7 minutes, man, out of Yamina. Okay.
Oh, my, okay. So, no screen me alarm diva. Okay. Matunos or screen share me alarm dino. Hello, ma.
Yeah, Talajare.
Oh, so ကျွန်တော်ဒီနေ့present လုပ်မဲ့ case လေးကတော့ထူးထူးခြားခြားတော့မဟုတ်ပါဘူးကျွန်တော်တို့ daily တွေ့နေတဲ့diabetic nephropathy case လေးပါပဲမှာဒါလေးကိုကျွန်တော်တို့ဘယ်လိုစဉ်းစားလဲပေါ့နော်အဲ့ဒါလေးနည်းနည်းထည့်စဉ်းစားတဲ့ approach လေးနည်းနည်းပြောဖို့ပါပဲ so so ဒီလူနာကတော့ကျွန်တော်တို့ 1stage ရဲ့ nephrology OPD ကိုလွှဲလိုက်တာပါနေရနေပြီးလွှဲလိုက်တာပါလူနာကတော့အသက်40အမျိုးသမီးပေါ့နော်သူတို့ကတော့ diagnosis ကတော့ diabetic nephropathy အနေနဲ့လွှဲလိုက်တာသူက diabetic man စတည်တာတော့လွန်ခဲ့တဲ့2နှစ်လောက်ကတော့စပြီးတော့ diabetic man စတည်တယ် diabetic တိကြတဲ့ကသူက pressure တက်နေတယ်ပေါ့နော်အဲ့တုန်းကတော့သူနေမှာက OH အနေနဲ့ sitagliptin ရဲ့ amlodipine antihypertensive အနေနဲ့ amlodipine ကိုတောက်ပြီးတော့သူ့ရဲ့ sugar control နဲ့pressure control ကိုသူသွားနေတယ်ဒါပေမဲ့နေမှာနေရတော့သူ့မှာအဲ့ဒီ diabetic control ကို check လုပ်ဖို့တော့ complication of diabetes တွေကိုသူ check လုပ်ဖို့အဆင်မပြေဘူးပေါ့နော်ဒါကြောင့်မလို့သူ check မလုပ်ဖြစ်ဘူးပြီးခဲ့တဲ့နှစ် March လောက်2019 March လောက်မှာသူစပြီးတော့6ရောင်လာတယ်ဆိုပြီးတော့သူ့ရဲ့ family physician ကိုသွားပြီးတော့ consult လုပ်တယ်အဲ့မှာအဲ့ဒီ6ရောင်တဲ့အချိန်မှာသူ့ရဲ့ other renal manifestation တွေဖြစ်တဲ့ hematuria တို့ frothy urine တို့သူ့မှာမရှိဘူးပေါ့နော်နောက်တခြား6ရောင်များတဲ့အကြောင်းရင်းတွေလည်းသူ့မှာမရှိဘူးbreathless exhaustion တို့ chest pain တို့ skin jaundice တို့ဒါတွေလည်းမရှိဘူးပေါ့နော်နောက်သူကငယ်ငယ်တုန်းကလည်းဒီလိုမျိုး renal နဲ့ပတ်သက်တဲ့ disease တွေမရခဲ့ဘူးမရှိခဲ့ဘူးဖော်လို့ရောင်လို့စိတ်ုံတက်ဖူးတာမရှိဘူးနောက်ဒီ systemic vasculitis ရဲ့ features တွေပေါ့ patient ကဖျားတယ် fatigue တို့ joint pain တို့ rash တို့ဒါတွေလည်းသူ့မှာမရှိပါဘူးနောက်သူက NSAID တွေပါဒီမတိုင်ခင်တောက်နေတာတို့ regular တောက်နေတာတို့နောက် other nephrotoxic agent တွေတောက်နေတာလည်းသူ့မှာမရှိဘူးဒါပေမဲ့သူ6ရောင်လာလို့သူသွားပြရတယ်ပေါ့နော်သွားပြရင်းနဲ့သူ့ရဲ့ family physician ကတော့သူ့ရဲ့ sugar control မကောင်းတဲ့အတွက် basal glycine နဲ့ glycoside ကိုထည့်ပြီးတော့ add လိုက်တယ်ပြီးတော့သူ့ medical check up လုပ်ပေးလိုက်တယ်ပေါ့လုပ်တဲ့အချိန်မှာ creatinine တက်လာလို့ဆိုပြီးတော့ creatinine တက်နေတာတွေ့လို့ဆိုပြီးတော့သူ့ YSH ကို diabetic nephropathy အနေနဲ့လွှဲလိုက်တာပေါ့နော် so YSH မှာလည်းသူတို့စေးကြည့်တော့ diabetic ရဲ့ other microvascular complication တွေကိုရှာကြည့်တော့လည်းမတွေ့ဘူးပေါ့နော် including diabetic retinopathy ပေါ့ကျွန်တော်တို့ eye specialist ကိုပါပြပြီးတော့ diabetic retinopathy ကိုရှာကြည့်ရဲဒါတွေလည်းမရှိဘူးပေါ့ဒါက Bishop ရဲ့ investigation summary ပေါ့သူ3လပိုင်းမှာသူ6ဆရောင်တဲ့အချိန်မှာသူ့ရဲ့ creatinine က135ပဲရှိတယ်သူ့ရဲ့ HbA1c က 12.4 ပေါ့နော် diabetic control ကတော့ပူအားဖြစ်တယ်sugar creatinine ကတော့135ပေါ့ဆိုတော့ eGFR ကအဲ့အချိန်မှာ42ပေါ့ဒီကျွန်တော်တို့စီမှာ follow up လာနေရင်းနဲ့ပဲသူ့ရဲ့ creatinine ရဲ့ rate of rise ကတဖြည်းဖြည်းမြန်လာတယ်GFR ကျတဲ့နှုန်းကလည်းမြန်လာတယ်ပေါ့နော်နောက်3လပိုင်းမှာသူစပြီးစစ်တဲ့အချိန်မှာ urine RE က protein urea က2 class လောက်ရှိတယ်hematuria က2 to 4လောက်ရှိတယ်ပေါ့နော်နောက်ကျွန်တော်တို့ဒီဘက် YSH ဘက်ကိုပြန်ရောက်တဲ့အချိန်မှာစစ်တော့လဲ protein urea က2 plus လောက်ရှိတယ် hematuria RBC လေးက2 to 3 per high power fee လောက်ပါတယ် CAS တွေတော့လုံးဝမတွေ့ဘူးပေါ့နော်ဆိုတော့အရင်တော့ကသူကတခါမှဒီသူ့ရဲ့ communication အတွက် check လုပ်ဖူးတာမရှိတဲ့အတွက်ကျွန်တော်တို့မှာက background data မရှိတော့သူ့ရဲ့ protein urea က gradually develop ဖြစ်လာလားရုပ်တရက်ကြီးပေါ်လာလားကျွန်တော်တို့အနေနဲ့မပြောနိုင်ပါဘူးprotein urea တွေ့တော့ခါကျကျွန်တော်တို့ကတော့ quantification လုပ်ရတာဘယ်လောက်များလဲဆိုတော့ UACR စစ်ကြည့်လိုက်တော့ UACR အများကြီးတော့မဟုတ်ဘူး 1.02 gram per gram လောက်ပဲရှိတယ်နောက် immunological investigation တွေလုပ်ကြည့်တော့လဲ ANA က 1/200 လောက် positive ဖြစ်တယ်ပေါ့နော် anchor ကတော့ negative ပဲ virus screening ဒီမှာလည်းဘာမှထူးထူးခြားမရှိဘူးဒါလေးသူ့ရဲ့ ultrasound ရိုက်ကြည့်တယ်ပေါ့နော် rate of creatinine rise ကမြန်နေတော့ကျွန်တော်တို့စဉ်းစားတဲ့ obstructive uropathy တွေပါများပါသလားပေါ့နော်ဒါပေမဲ့သူ့မှာ no evidence of unilateral obstruction kidney size ကတော့ကောင်းတယ်ပေါ့နော်ဆိုတော့ kidney size ကတော့ diabetic nephropathy ဆိုရင်လည်း kidney size ကကောင်းနိုင်တယ်CM cortical echo လေးနဲ့တက်တာကလွယ်ရင်ကျန်တာတွေကသူ့မှာထူးခြားမရှိဘူးပေါ့နော်ဆိုတော့ကျွန်တော်တို့ဒီလူနာကိုမြင်လိုက်တာတော့ type 2 diabetes ပဲ hypertension နဲ့သူ့ရဲ့ nephropathy ပေါ့ nephropathy ကဒီလူနာရဲ့ diabetic nephropathy ဒါက diabetic nephropathy လားပေါ့ဒါမှမဟုတ်ရင် non diabetic kidney disease တွေသူ့မှာရနေတာလားပေါ့နော်ဆိုတော့ကျွန်တော်တို့စဉ်းစားတာကဒီလိုလေးသွားတယ်နောက်တစ်ခုကတော့ဒီမှာဂျားပြတ်ပြီးပြောချင်တာကတော့ကျွန်တော်တို့မှာ terminology တွေရှုပ်နေတာပေါ့နော်diabetic nephropathy ရဲ့ terminology ပေါ့ဒါပေမဲ့ diabetic nephropathy ဆိုတာကတော့သူကဘာကိုဆိုလိုတာလဲဆိုတော့ is a diagnosis that refer to specific pathologic structural and functional changes seen in kidney of patient with DM that result from effect of DM on kidney ပေါ့ဆိုတော့ effect of DM on kidney ကြောင့်လို့ဖြစ်တဲ့ pathologic structural and functional changes ကိုကျွန်တော်တို့ကမျက်မြင်ကိုယ်တွေ့ဖြစ်ရမှာပေါ့ဆိုတော့ renal biopsy လို့ရပေါ့ diabetic nephropathy လို့ပြောဖို့အတွက်ဆိုရင် renal biopsy ကြည့်ပြီးမှ diabetic ရဲ့ changes တွေတွေ့ပြီးမှ diabetic nephropathy လို့ပြောမယ်ပေါ့နော်ဆိုတော့နောက်တစ်ခု term တစ်ခုက diabetic kidney disease ပေါ့ diabetic kidney disease ကတော့ဒါကတော့2019ဒီ journal မှာပါတဲ့ဟို definition လေးကိုယူထားတာပါသူကတော့ diabetic kidney disease ဆိုတာက usually refer to CKD ပေါ့ as a consequence of diabetes ကြောင့်ဖြစ်တဲ့ CKD ပဲအဲ့တော့သူက CKD ရဲ့ definition ဝင်ရမယ်ပြီးလို့ရှိရင်သူက without confirmation or diagnosis by kidney biopsy ပေါ့ kidney biopsy မပါဘူးပေါ့နော် kidney biopsy မပါဘဲနဲ့diabetes ကြောင့် CKD ရတယ်လို့ယူဆပြီးတော့ထားလို့ရှိရင်တော့ဒါကို diabetic kidney disease လို့ခေါ်တယ်ပေါ့နော်ဆိုတော့ဒါကတော့ဒီ nephrology dialysis transplantation 2019မှာထွက်တဲ့ journal ရဲ့ definition ကိုပြောထားတာပါဆိုတော့ကျွန်တော်တို့ကဒီ patient ကို diagnosis or diabetic nephropathy ဟုတ်လားဆိုတာသိဖို့အတွက်ဆိုတော့ other diabetic nephropathy တွေရောဖြစ်နေမလားဆိုတာ define identify လုပ်ဖို့လိုပါတယ်ဆိုတော့ဒီမှာကျွန်တော်တို့ဒါ2019ဒီ American Clinical Journal of American Society of Nephrology မှာပါတဲ့ပုံလေးပါသူက diabetic နဲ့ non diabetic kidney disease တွေဘယ်လိုခွဲလဲဆိုရင် onset အရာပေါ့နော် onset of proteinuria က non diabetic kidney disease ကပို့ပြီးတော့မြန်ဖြစ်တယ် diabetes တွေကသူ့ရဲ့ course အတိုင်းပဲပထမဆုံး microalbuminuria လာတယ်ပြီးတော့မှ macro ဖြစ်တယ်ပြီးတော့မှ over ဖြစ်လာဟို creatinine တက်လာတယ်ပေါ့နော်ဆိုတော့ဒီလူနာမှာတော့ကျွန်တော်တို့ကဒီ rapid ဖြစ်လာမဖြစ်လာကို baseline မရှိရတော့ကျွန်တော်မသိပါဘူးပေါ့နော်ဒါပေမဲ့ progression of CKD ကမြန်နေတာတော့သိကြတယ်rapid ဖြစ်တယ်နော် duration of diabetes ကလည်း 2 year ပဲရှိသေးတယ်ဆိုတော့non diabetic kidney disease ဖြစ်ဖို့တော့ပုံများတယ်ပေါ့နော် urine analysis မှာလည်းhematuria လေးအနည်းငယ်တွေ့နေတယ် diabetic မှာတစ်ခါတရံ hematuria လေးရတတ်တယ်ဆိုပေမဲ့ဒီ patient မှာတော့ persistent လေးရနေတာတော့တွေ့ရတယ်နောက်ပြီးတော့ other diabetic complication ဖြစ်တယ် diabetic retinopathy ကဒီ patient မှာမရှိဘူးပေါ့ဒါကြောင့်မလို့ကျွန်တော်တို့က non diabetic kidney disease များဒီ patient မှာရှိနေမလားလို့စတွေးမိတယ်ပေါ့နော်ဒါကလည်း other approach တစ်ခုပါပဲဆိုတော့ဒါကြောင့်မို့ကျွန်တော်တို့ကဒီလူနာကိုရှင်းပြတယ်diabetes တစ်ခုတည်းတော့မကလောက်ဘူးပေါ့နော်တခြားတစ်ခုများပါနေမလားအဲဆိုရင်ကျွန်တော်တို့မှာ diabetes nephropathy အပြင်တခြားဟာကိုကုလိုက်လို့ရှိရင်သူ့ရဲ့ဒီ kidney course disease course ကပြန်ပြီးတော့progression ကနှီးသွားအောင်တားနိုင်မယ်ပေါ့နော်ဒါကြောင့်မို့ဒီ patient မှာကျွန်တော် renal biopsy လုပ်လိုက်ပါတယ် renal biopsy လုပ်လိုက်တော့ဒါကတော့ renal biopsy ကျွန်တော်တို့ဆရာဇင်ဖြိုးနိုင်ကြည့်ပေးထားတာပေါ့နော်ဒါ HNE stain မှာတော့ဒါ messenger proliferation လေးတွေတွေ့ရတယ် messenger မှာဒီ proliferated changes လေးတွေရှိတယ်နောက်တစ်ခုကတော့ဒါ PAS stain ပေါ့နော် PAS stain မှာတော့ဒီမှာဆရာပြထားသလိုပဲ segmental sclerosis လေးရှိတယ် glomerulosclerosis ပေါ့နော်နောက်ဒီမှာလည်း messenger proliferation လေးတွေရှိနေတယ်ဒါကတော့ဟို sclerosis ဖြစ်သွားတဲ့ glomeruline ပေါ့နော်ဒါတွေကတော့တခြား messenger proliferation ရဲ့ features တွေပေါ့ဆိုအဓိကတော့ဗာတွေတွေ့နေလဲဆိုတော့ messenger proliferation နေတွေ့နေတာပဲပေါ့နော်ဆိုတော့ messenger proliferation က gamma-sin တွေကို diabetic nephropathy မှာလည်း messenger proliferation တွေ့နိုင်တယ်နောက်ပြီးတော့ messenger proliferated GN တွေမှာလည်းဒီလိုမျိုး messenger proliferation ဆိုတာတွေ့နိုင်တယ်ပေါ့ဆိုတော့ကျွန်တော်တို့ကဒီဟာတွေကိုခွဲဖို့အတွက်ဆို immunofluorescence ဆက်ပို့တယ်ပေါ့နော် immunofluorescence မှာဆိုရင်ဆို IgG immunofluorescence မှာ IgG stain ဆိုတော့ IgG က negative ထွက်တယ်နောက်ဒါကကျွန်တော်တို့ IgM ပေါ့နော်ဆို IgM မှာလည်းဘာမှသိထူးထူးခြားမတွေ့ဘူး negative ပဲဒီမှာကြည့်လိုက်လို့ရှိရင်တော့ဒါ IgG stain ပေါ့နော် IgG ကြားရင်တော့ IgG မှာဆိုလာပြီးတော့ positive ထွက်တယ်နှစ်ခု2+ လောက် positive ထွက်တယ်ဒီမှာလည်းဒါ IgG positive ဖြစ်တဲ့ glomeruline တွေပေါ့နော်ဆိုဒါကတော့ C3 stain ပေါ့ C3 မှာလည်း negative ပဲနောက် C1Q လည်း negative ပဲနောက်တစ်ခုကဒါ kappa stain ပေါ့နော် kappa lambda ပေါ့နော်ဒါကတော့ fibrin ပေါ့ဆိုတော့ fibrosis လေးလည်းသူမှာရှိနေဆိုတော့ဒါကတော့ဟို biopsy ရဲ့ဖြေပေါ့နော် renal biopsy ကတော့သူကပထမတော့ consistent with diffuse diabetic glomerulosclerosis နဲ့နောက် mesangial proliferated glomerulonephritis with 2+ IgA နဲ့ fibrin mesangial deposition ဆိုပြီးတော့ပြောဆို final diagnosis ကတော့သူကdiffuse diabetic glomerulosclerosis with IgA nephropathy ပေါ့နော် so ကျွန်တော်ရဲ့ဒါ final diagnosis ကတော့ patient type 2 diabetes poorly control နောက်ပြီးတော့ diabetic nephropathy with concomitant IgA nephropathy ပါနေတာပေါ့နော် so ဒီလိုမျိုးပေါ့ diabetes patient ဖြစ်ပြီးတော့ other diabetes ပြန် non diabetic renal disease တွေဖြစ်နိုင်တဲ့ chance တွေပေါ့နော်ဒါကဟိုနိုင်ငံခြားသူတို့လုပ်ထားတဲ့ study ပါ diabetes patient တစ်ဝက်ကျော်လောက်မှာ diabetes မဟုတ်ဘဲနဲ့တခြားrenal disease တွေပေါ့နော်ဆိုတော့ဥပမာ glomerulonephritis ဒီမှာဆို IgA ကသူက 5.6% လောက် IgA ကိုတွေ့ရတယ်ဆိုတော့ဒါကတော့ကျွန်တော်တို့နိုင်ငံမှာဆရာကျော်တီဟာဆိုဟိုရဲ့ study ပေါ့နော်ဆရာကျော်တီဟာဆိုလုပ်ထားတာသူရဲ့ inclusion criteria မှာပါတဲ့လူနာတွေကိုသူဘာစီယူကြည့်တဲ့အချိန်မှာတော့non diabetic renal disease က28ယောက်ရှိတယ် diabetic nephropathy ဆိုပြီးတော့ထွက်တာ6ယောက်ပဲဆိုတော့ total 33ယောက်လုပ်ထားတဲ့အချိန်မှာ non diabetic renal disease က28ယောက်ရှိတယ်ဆိုတော့အများစုကတော့
1 minute left
ဟုတ် ဆိုတော့ဒါကတော့ကျွန်တော်တို့treatment ပေးလိုက်တာပေါ့နော် treatment ကတော့ဟို IIG အတွက်တက်မီစာတန်ပေးတယ်နောက်တစ်ခုကတော့ဟို lipid control ကောင်းအောင်လုပ်တယ်နောက် prednisolone ကို low dose စာပေးလိုက်တယ်ပေါ့နော်ဆိုတော့ဒါကတော့သူနောက်ဆုံး prednisolone ပေးလိုက်တဲ့ dose date ကနေစပြီးတစ်လ follow up မှာသူ့ရဲ့ creatinine တော့ပြန်ကျလာတယ်ကံကောင်းတာကတော့ तू ကအဲ့တစ်လပြီးနောက်တစ်လပြန်မလာတော့ကျွန်တော်တို့နောက်ထပ် follow up တော့ထပ်မရှိတော့ဘူးပေါ့နော် so ကျွန်တော် presentation မှာပဲကျေးဇူးတင်ပါတယ်အားလုံး
ဆရာဝေဖြိုးကျေးဇူးတင်ပါတယ်အဲ့တော့ဒီမှာနည်းနည်းမေးစရာတွေတော့ရှိမှာပဲเนาะအဲ့တော့ chat box မှာပဲဖြစ်ဖြစ်မေးခွန်းတစ်ခုတော့ short question ဆိုနှစ်ခုမေးဖို့အလောင်းလုပ်ပါတယ်။ဘာများမေးချင်ပါလဲ။အမနည်းနည်းမေးမယ်နော်။အဲ့တော့ diabetic လို့ဆိုရှင် renal involvement ရှိဖို့ကတော်တော်လေးတည်ကြတာပေါ့နော်။အဲ့တော့ဘယ်လိုလူတွေမှာမတို့ကစီချိုသမားတိုင်းကိုတော့ဘာမှမလုပ်ဘူးလို့ထင်တယ်လေ။ဘယ်လိုလူတွေမှာဘာမှစီချိုလည်းရှိရသားနဲ့ပေါ့နော်။ renal biopsy ကိုစဉ်းစားမလဲဘယ်အခါမှာအဲ့ဒါလေးတစ်ခုတော့သိချင်ပါတယ်
ဆိုတော့စီးကျူသမားတိုင်းတော့မှဟိုပေါ့ဟိုဘာစီမလုပ်ပါဘူးဒါပေမဲ့ဘယ်လိုလူမျိုးတွေမှာလုပ်လဲဆိုတော့ခုနကကျွန်တော်တို့ဟို American Journal of Kidney Disease မှာပါသွားတဲ့ပုံလေးအတိုင်းပဲပေါ့နော်ဟော diabetes duration ကဟိုပါပေါ့9နှစ်အောက်မှာဖြစ်နေတယ် type 1ပေါ့နော် type 1 diabetes ဆိုတော့ diabetes duration က9နှစ်အောက်မှာဖြစ်နေတယ်slide share ရမှာdiabetes duration က9နှစ်အောက်မှာဖြစ်နေတယ်နောက်ပြီးတော့ GFR decline ကလည်းအញ្ញမ်းမြန်တယ်ပေါ့ rapid GFR decline သတ်မှတ်ထားတယ်ကျွန်တော်တို့5 ml ပါတစ်နှစ်ကို5 ml ပါ minute ပဲကြာရမှာပေါ့အဲ့ထက်ပိုပြီးတော့မြန်နေတယ်ဆိုရင်တော့၎င်းပေါ့အဲ့ဒါဆိုရင်တော့ကျွန်တော်တို့ကdiabetes plus ကိုစဉ်းစားဖို့ကောင်းတယ်ပေါ့နော် diabetes plus ကိုစဉ်းစားဖို့ကောင်းတယ်နောက် protein urea ကသူက gradual ဖြစ်ရမယ် microalbumin urea ပြီးမှနောက် over protein urea ဆိုတာလာရမယ်microalbumin urea မလာခင် over protein urea ကျိုလာလို့ရှိရင်လည်းကျွန်တော်တို့ကစဉ်းစားမှာပေါ့နော် other evidence of extra renal manifestation or systemic features systemic vasculitis features တွေရှိလို့ရှိရင်အဲ့လိုမျိုးဆိုလည်းကျွန်တော်တို့ကother diabetes plus လာဆိုတာမျိုးစဉ်းစားဖို့လိုပါတယ်
နောက်မိခွန်းတစ်ခုကတော့လေ IgA nephropathy ရဲ့prognosis ကိုပြောပြပါရစေဆရာဝင်းကိုမေးထားတာပါ
ဆို IgA nephropathy ရဲ့ prognosis ကတော့လေကျွန်တော်အချိန်မရလို့မထည့်ထားလိုက်တာ IgA nephropathy နဲ့ဒီ case မှာတော့သူကနှစ်ခုဖြစ်နေတာပေါ့နော် IgA nephropathy နဲ့ diabetes နဲ့ရောနေတော့ဟို prognosis ကတိတိကျကျပြောဖို့ခက်တယ်ဒါပေမဲ့ IgA nephropathy အလုံးဆိုရင်တော့သူ့ကို prognosis တွက်တဲ့ prognosis marker ရှိပါတယ်အဲ့ဒီဟို QX မှာကျွန်တော်တို့ international IgA nephropathy တွက်တဲ့ဟိုဟာလေးဟို QX calculator ထဲမှာအဲ့ဒါလေးထည့်တွက်လိုက်လို့ရပါတယ်တော့ဒီ browsing finding ရယ်သူ့ရဲ့ age ရယ်နောက်အသက်ရယ်ဒါလေးထည့်တွက်လိုက်လို့ sorry race ရယ်ဒါလေးထည့်တွက်လိုက်လို့ရှင်နောက်5 year မှာ ESRD ဖြစ်နိုင်တဲ့ risk ကိုသူကအတိအကျထွက်ပေးပါတယ်
နောက်မိခွန်းတစ်ခုက when and how to order urine DM patient to exclude early detection of DM nephropathy အဲ့ဒါမေးထားပါတယ်ဆရာမောင်မောင်တက်မေးထားတာပါ
ဟိုဒီ diabetes nephropathy အတွက်တော့ဟိုသူ့ diabetes patient တွေမှာပုံမှန်စစ်နေကြ routine UACR စစ်တယ်လို့ဟို6 monthly စစ်တယ်ဆိုတော့6 monthly ပေါ့နော်အဲ့အတိုင်းပဲစစ်ရုံပါပဲသူ တူကြတော့ဟိုမရှိပါဘူးဆရာမောင်တန်း
ကျေးဇူးအများကြီးတင်ပါတယ်ဆရာဝေဖြူအဲ့တော့အခုsecond speaker ဆိုတတိယ speaker ပေါ့နော် cardiology work ပါ a case of facial congestion interesting case ပေါ့နော်ဒေါက်တာအီချိုခိုင်ကိုဖိတ်ခေါ်ပါတယ်ဆရာဝေဖြိုးကျေးဇူးပါအတန်ကြားလားမသိဘူးကြားတယ်
good afternoon, and I felt very honored to share an interesting case on behalf of the Cardiology Department, Yangon General Hospital. So our case was the 68-year-old smoker from Netaway, consulted to our cardiac department on the June 2020, presenting with the worsening of the exertional dyspnea, lethargic with the reduced appetite for the 2 months duration prior to the presentation. He noticed the facial edema and non-specific chest pain, and he had no known medical problems. On examination, we noticed the facial swelling, dilated neck veins, vital signs are quite stable, no murmurs on the cardiovascular examination, no signs of heart failure, and no organomegaly. So this is his chest X-ray, and definitely there was a cardiomegaly. And ECG show sinus bradycardia. So we performed the transthoracic echo. So these are the 2D images of the person now exists. In the first 2 images, you can see that there is a left ventricular size and the functions are within normal limit. Valves are quite okay with the mild mitral regurgitation jet. And then for chamber view, definitely there is a enlarged right atrium and then right ventricle. And there is a large intra-atrium mass inside the right atrium, involving the epi and the myocardium of the right atrium. When we pay more attention to the lesion, we can see that there is the infiltrated mass extending into the wall of the right atrium and into the wall of the right ventricle, and also part of the interatrial septum. So this image is the subcausal view of the subcausal view of the 2D images. Here we want to show you the inferior vena cava draining freely into the right atrium, involving the epi and myocardium, draining freely into the right atrium, excluding the extension of the
Yeah, what cause facial pain?
So this is a subcausal view. We want to show you the right inferior vena cava draining into the right atrium. So excluding the extension of the intra-abdominal malignancy, like venous carcinoma extension into the right atrium. These are the 2D images, cine images of the transesophageal echo. Here we can see more clearly about the lesion of the nature of the lesion. This is an inhomogeneous infiltrated mass inside the right atrium, right ventricle, and then in the atrial septum. Valves are quite normal. Only the mild regurgitant lesions, mild pericardial effusion is noted. So from that finding, we concluded that that would be a malignant cardiac tumor in our first thinking for the diagnosis. Firstly, we consider the cardiac sarcoma, angiosarcoma, which is the most prevalent cardiac malignant tumor, followed by the cardiac lymphoma and then cardiac mesothelioma. Secondary metastatic tumor with the cardiac infiltration can also be considered. And although it is less likely, we also need to think about the cardiac myxoma and then thrombus like the benign lesion. So in reviewing the patient hematogram, there was the pancytopenia. Liver and renal functions are quite normal. So because of the pancytopenia, we consulted with the hematology department, and then bone marrow examination was done, and it was found to be the myelodysplasia. So we proceed with the multi-phase CT chest, abdomen, and pelvic to find out the primary or the secondary nature of the mass or lesion. And here the coronal and then axial reconstructed CT images show that there is a large intraluminal mass inside the right atrium and also in the right ventricle, and some extension into the superior vena cava. IVC is quite clear, and then both lungs and then intra-abdominal organs are quite normal. No hilar or mediastinal lymph node enlargement, and then no para-aortic lymph node enlargement. So the CT diagnosis was the cardiac tumor in the right atrium and the right ventricle. The differential goes for the myeloma, myelofibroblastic sarcoma, and then fibroelastoma. So with the help of the cardiovascular surgical department, we got the tissue for the proper diagnosis. And then with the help of the Professor Newton Ding and team from the Department of the Pathology, Yangon General Hospital, we got the tissue diagnosis. It was found to be the non-Hodgkin lymphoma, diffuse small to the medium-sized clear cell lymphoma on the immunohistochemical staining. So our final diagnosis was the primary cardiac lymphoma. So we referred him to the hematology department, and then chemotherapy was started and completed 6 cycles recently, and he was complicated with the pleural effusion during the chemotherapy. Although we cannot perform the post-chemotherapy echo recheck during the COVID pandemic, he is still quite doing well. So on reviewing the literature, cardiac involvement of the systemic lymphoma is seen in up to 20% of the cases. Primary cardiac lymphoma is quite rare, 1.3 to 2% of the all cardiac tumors and 0.5% of the extranuclear lymphoma. B-cell non-Hodgkin lymphoma are the most common histology subtype. Right cardiac chambers are usually involved. Pulmonary embolism, AV block, pericardial effusion or constricted pericarditis, and then the cardiac wall rupture related to the primary cardiac lymphoma are usual presentation. High level of suspicion and then proper diagnosis is crucial for the primary cardiac lymphoma because it is rapidly progressive and fatal. So the reason for our presentation is that it's a rare case with the atypical presentation. And in our case, there was a diffuse infiltrative involvement of the both RA and RV without extracardiac involvement. Thank you for attention.
Thank you, Dr. for very informative presentation. Because of time allowance, I think we can count one short question from audience. Once again, Q&A. What is the echo features of sarcoma or lymphoma different from myxoma?
Usually the sarcoma is the malignant tumor, and then myxoma are usually the benign. Almost 95% of the cardiac tumors are usually the benign tumor with the myxoma, and then myxoma usually appear in the left-sided, mainly the left atrium, and usually attached arising from the interatrial septum. And there is some like a stock attachment to the interatrial septum or the intracardiac wall, and it is not very homogeneous and very not extensive in nature. For the malignant tumor, they usually tend to be more common in the right-sided lesions with the right atrium, right ventricle, very extensive in nature, and rapidly progressive in nature. So that's the differentiating point in echo. Thank you.
All right, it is so much about you, Marshall. Just me, Dr. Ichulun. So now, don't you present about the Dr. Docking, Pamoka Docking Bibia, Celebi or Chain is on about me. Speak out, just
Minglawashi. Tomorrow, chain the rolling, Peter the Jamu, tomorrow first section, Sawame. Tomorrow, don't come up, tomorrow to Quaro, Dr. Ausin you are, COVID era ma, acute coronary syndrome, Balumia, managed to like the lesser, Chila Jama. Dr. Ausin you, please.
Good afternoon, all my respectful professors and my senior and my colleagues. Today, I would like to present about the case about management of acute coronary syndrome in the COVID-19 era. The aim of the management of acute coronary syndrome is to save the patient and to save the myocardium as possible. In addition, to protect the medical care personnel from the COVID-19 infection and to prevent the disease transmission is another aim in this COVID-19 era. This is a case, 36 years old, captain physician from our hospital, number 1 DSCH, admitted on 13 November 2020 with a complaint of epigastric and chest discomfort, which is related to the left arm at the 12 noon of 13 November 2020. He suffered short duration paroxysmal chest pain last 2 days, and which was associated with sweating and dizziness. He got syncopal attack for one time before hospitalization, and he got breathlessness, dyspnea, and orthopnea. He has the CVD risk of obesity, and he is a chronic heavy smoker. He has dyslipidemia, and he is non-diabetic and hypertensive. On examination of the patient is pale looking and he is in shock and dyspnea, confused. Blood pressure is 60 millimeter mercury per paper and heart rate is 60 beat per minute after an episode of bradycardia. Heart sounds are normal and glance reveals few basal crackles in the both flanks and abdomen is soft. His initial ECG revealed ST elevation, inferior myocardial infarction, and reciprocal changes in the anterior leads. Initial echocardiography was done, and echo shows akinetium, scarring anterior wall and septum, and stent inferior wall with overall EF of about 20%, severe LV dysfunction. So urgent investigations were done. COVID-19 rapid test negative, troponin and CKMB are high, and urea creatinine electrolytes are normal. CP also normal and serology is clear. So we give him dual antiplatelet with aspirin 300, clopidogrel 600, and duvastatin 80 milligram, and then IV endotrope for shock, and we decided to do primary PCI. Okay. There's, so I'll show the angiogram report after the presentation because of some technical problem. So in this case, we target to do primary PCI within 120 minutes, and then he is arrived in time to our hospital. And the problem is that this is in the COVID-19 era, and we do COVID-19 RTT and nasal swab on admission. We try the intervention by revascularization of the capillary lesions and complete revascularization after stabilization, because there is the evidence of LAD occlusion in the echo, and we use the equipment with usual cath lab and personal protection using level 2 PPE and 95 marks and possible least person. We do the procedure with one primary operator, one second operator, and only one assistant and one anesthesiologist for the patient. We do the disinfection with UV light in the cath lab after the procedure. The advantage we got in this case is that COVID-19 test is readily available in our hospital. Regarding the acute coronary syndromes in COVID-19 era, the incidence of acute coronary syndromes is not uncommon because ACS increases in the setting of the viral infection, likely due to inflammation-mediated plaque destabilization. There are also direct and indirect myocardial injury due to the viral infection. Additionally, there are multiple rows of STEMI mimics, which will come with the evidence of myocardial injury by rise troponin and then ST elevation in ECG, but maybe due to the myopericarditis. But in this case, there is regional wall motion abnormalities and there is risk factor. So we are sure that he got ACS and so decided to go for primary PCI. Primary PCI is the intervention of choice even in this era, and fibrinolysis should be reserved for the extreme resource constraints and carefully selected patients. So management of ST elevation MI in this era, the patient safety and the healthcare personnel safety is the paramount of the management. So primary PCI remains the reperfusion therapy of choice. The PCI pathway may be delayed due to the implementation of the protective measures and delay in the delivery. So sometimes fibrinolysis should become the first therapy. All TB patients should undergo testing for SARS-CoV-2 as soon as possible on admission, and they should be considered as potentially infected patients. And the complete revascularization is indicated if it is feasible, but then coverage lesion should be handled fast. According to the patient clinical stability, we should do the non-coverage lesion intervention. So some of the ESC guides in the STB in COVID-19 era also are there, and then they categorize them in high risk, low and moderate risk, and they can wait for days. And then in the case of the STE-MI, COVID-19 testing results are usually obtained before the further determination of the patient care plan. In this case, luckily the patient is lucky he survived, and the team is lucky because the COVID-19 PCR is negative in this patient. Thank you very much for attention. I would like to share the video. There is some.
Kanali sao mashe video le try to jin pare technical ပြဿနာလေးဖြစ်လို့ပါအဲ့ဒါလေးစောင့်နေတဲ့အချိန်မှာတော့ဒီမှာမေးထားတဲ့ question ကတော့is ACS can occur without risk factor? What are the risk factors in your patient set เนาะ video လေးကိုဖွင့်ရင်းနဲ့အဲ့ဒါလေးလည်းပါစကဖြေလိုက်ပါဦး
ဒီ patient မှာ risk factors ကတော့ obesity နဲ့ကျွန်တော် dyslipidemia နဲ့ chronic smoking ပါဗျာwithout risk factor လည်း ACS ကဖြစ်နိုင်ပါတယ်ဖြစ်နိုင်တယ်ဆိုတာက
angio လေးထွက်လာပြီဆိုပြောလိုက် angio လေး
you can see there is total occlusion of the right coronary artery, and then after wiring there is very little flow in the distal part, so we decided to do pre-dilatation, and then now the first stent is deployed. I think one stent was enough, but that is the end of the stent. There is some stenosis, and so I decided to do another stenting. After that, he got reverse of the right coronary artery. Post-dilatation done with 3O short balloon. This is the RCA. On the left side, you can see the total occlusion at the osteoproximal LED. I just turned with a simple wire for one turn to LED, but it is still, and so we decided to do complete revascularization later. Thank you for your kind attention. Sorry for the inconvenience due to the technical error. Thank you very much.
ဟုတ်ပါဘူးဆရာအောင်စီမျိုးတို့ team ကို patient ကလည်း cardiogenic shock နဲ့လာတယ်ဒီဥစ္စာကိုပဲတကယ်ကို within window period မှာပဲ coronary intervention အောင်မြင်လုပ်နိုင်တာ congratulate လုပ်ပါတယ်question လေးဆိုရင်တော့တစ်ခုလောက်ပဲရပါမယ်ကျမတို့အချိန်မရှိလို့ပါအဲ့ဆိုရင် chat box မှာတချို့ဖြေထားတာမေးထားလေးဆက်ဖြေလိုက်ပြီကျမတို့ second case ကိုတွားလိုက်ပါမယ်ရှင် second case ကတော့ gastroenterology department က Dr. Tira Soa passing the puzzle ပါသူ gastroenterologist တွေ puzzle လေးကိုဘယ်လိုများ pass လုပ်တယ်လဲနားထောင်လိုက်ရအောင်ပါရှင်
Good afternoon, ladies and gentlemen. May I present a case, Pass in the Puzzle, on behalf of the Department of Gastroenterology, Yangon General Hospital. The patient is 35-year-old gentleman, businessman, and the complaint of the loose motion 2 years duration. His symptoms started since 2018, which is the watery, and the same day 3 times per day, but in same day, maximum 10 times per day, no blood, no mucus, but associated with the diffuse abdominal pain, but patient had no fever. He had no relevant history of past medical, surgical, and drug history, and no relevant family history of GI malignancy. Because of his symptoms, he consulted with a gastroenterologist and visit blood tests done, and it showed that mild leukocytosis with eosinophilia 10% and lymphocytosis, reduced total protein count, and absolutely reduced the albumin level, 18 gram per liter. At that time, the OGTS and colonoscopy done, and it is unremarkable. His symptoms were not subsided totally with the antibiotics and the supportive treatment. So he went to the Bangkok and consulted at the Bangkok 2018 December. And there are a series of the blood tests were done, including the hormonal assay as well as the imaging study like the MRI brain. Their working diagnosis was the query adrenal insufficiency due to the low serum cortisol level. So they prescribed steroid, and the patient took hydrocortisone tablet BD for 7 months duration. And he felt that symptoms were relieved for a while, so he stopped steroid himself. But in June 2020, he suffered again the loose motion, vomiting after meal, and the marked lower limbs edema. At that time, because of the COVID era, he could not able to go to Bangkok and didn't seek the follow-up. So he consulted again with us and admitted at our department. On examination, the patient was cathected, anemic, and it looks the depressive mood because of the chronic illness. And the abdomen is slightly distended and free fluid detected and no palpable mass. Marked bilateral patent edema was noted. This table shows the series of the full background. This is at the time of his at the start of his symptoms, mild leukocytosis and eosinophilia and hypoalbuminemia. 1 year later, chronic microcytic anemia and similar pattern, leukocytosis with eosinophilia and hypoalbuminemia. Similar pattern like that, and this is 2020, and still the hypoalbuminemia present with eosinophilia. Even though we give the albumin infusion, albumin level raised transiently. We did a series of the stool examination like the stool RE, stool CNS, and stool antigen for protozoa and the C. diff toxin. They all are unremarkable. So at that time, we did again the EGD and colonoscopy to find out his problem. And it shows that gastric wall is markedly edematous and erythema. And this is the duodenal wall. Duodenal wall is marked mucosal erythema, edema, and superficial erosions are noted. Apart from that, there's no obvious finding. So but we took the biopsy from the second part of the duodenum. At the colonoscopy, apart from the diverticulosis, no obvious positive findings. But we took the random biopsy from the right colon and the left colon. Both endoscopic biopsy turned out chronic non-specific duodenitis, ileitis, colitis, and the proctocolitis. Because of this hypochromic microcytic anemia, we did the video capsule endoscopy to find out the small bowel lesions. Similarly, like the OGTS, marked mucosal edema and superficial erosions and the erythema are noted, and jejunum and the duodenum. So we proceeded the CT abdomen. It showed that mild hallucination with edematous and slight thickened wall of the duodenum, jejunum, and prominent wall in the iliac loop. Enlarged celiac, para-aortic, mesenteric, and right ileocolate nodes, and mild ascites. Radiologist's opinion is inflammatory or infected small bowel disease or small bowel enteritis. So we have the positive findings is that abdominal lymph node enlargement. So we discussed and consulted with the surgeons to take the abdominal lymph node biopsy to find out his problem. So diagnostic laparoscopy followed by the mini laparotomy was done on the 1st August 2020. This is the intraoperative finding, and this is a terminal ileum. Multiple third mural nodules, 5 dish nodules, here are also seen in the terminal ileum. So the surgeon took the wedge recession of the terminal ileum and sent for histopathology. It turns out numerous acute and chronic inflammatory cells, including the eosinophilia, are seen. Multiple X or the strongylitis tacruralis are seen within the mucosal epithelium as well as in the lumen. There is no features of dysplasia and malignancy. Strongylitis tacruralis is a nematode parasite. It is a swine-transmitted hermit, and its characteristic is the auto-infection. The entire life cycle is within the host, and it can survive for a long time with or without the meningeal symptoms. They are severe and life-threatening in patients who are taking the steroid and other immunocompromised conditions. The right microscopic observation of the parasite in the thick smear feces show the low sensitivity, can only detect the 30%. Eosinophilia is another prognostic marker in infected patients with intact immune system. Ivermectin and thiopentazole have superior to the albendazole. Ivermectin is drug of choice. Standard dose is 200 microgram per kg for 2 days. However, patients with hyperinfection and disseminated disease should be administered daily until the symptoms has resolved and never have not been detected for at least 2 weeks. In our case, we gave the ivermectin 12 mg OD for 3 weeks duration. Surprisingly, 48 hours after taking the ivermectin, patients feel that can eat well and no vomiting after meal, and obviously noted the decreased frequency of his motions. 1 week later, no more loose motion and edema subsided totally. This is the blood picture. 1 week after the ivermectin, anemia and the eosinophil count is upper limit, and 3 weeks after ivermectin, eosinophil count is within normal, and the albumin levels return back to normal. This photo was taken at the time of the hospitalization before the surgery, and this is taken recently. He told that his body weight increased by more than 40 pounds. He can do his work and he can go his routine activity. In this case, it is the first experienced case of strongylitis tacruralis infection and organ involvement. In the patients with hypoproteinemia, loose motion, and anemia, tropical disease should be considered, and because it is a curable disease. Teamwork is important to get the correct diagnosis and to save patients' life. Our special thanks to the Professor Daniel Surgeon for doing the lymph node biopsy, and Professor Minzo Wu for taking care of every center, and pathologist Dr. Mimi Miatu for helping us a lot to get the correct diagnosis, and lastly, the patient and his family. Thank you for kind attention.
Thank you, Dr. Tira So, no? Strongylitis tacruralis နဲ့ပတ်သက်လို့ပြန်ပြီးရဲ့ခါကျဒီလောက်ထိ tissue invasive တွေဖြစ်တာရှာပါပါနဲ့ကျမတို့လည်းဒါပဲတွေ့ဘူးတာပါ question လေးတစ်ခုနှစ်ခုလောက်တော့ allow လုပ်လို့ရပါတယ်
Clinica antihelminthics တွေ like တဲ့ albendazole ရော strongylitis မှာ action ရှိလား
ဒီမှာစပေါ့ပြောထားတာကတော့ဒီ albendazole တဲ့စာလို့ရှင် ivermectin ကပို့ပြီးတော့ကောင်းတယ်ပေါ့နော် albendazole study လုပ်ထားတဲ့အခါမှာဒီ albendazole ပိတ်ကြည့်တဲ့အုပ်စုတွေမှာဆိုလို့ရှင်သူကဒီ eradication ကနည်းတယ်ပေါ့နော် albendazole ကိုနောက် study တစ်ခုမှာကြတော့သူ BD ကို 1 week လောက်တည်ပေးထားတဲ့အခါမှာတော့ eradication နည်းနည်းရတယ်လို့ပြောတယ် literature တွေမှာတော့ivermectin is the drug of the choice ပါပဲမမ
အဲ့တော့ဟိုဒါကတော့အမတို့ကလေပုံမှန်ဆိုရင်ဒီတန်းချဆေးကိုပဲလော်စားလို့ပေးတာဆိုတော့လေဝင်းရှော့လည်းပေးတယ်ဘဲအောင်လည်းပေးတယ်ပိန်လည်းပေးတယ်ရားတယ်ဆိုလည်းပေးတယ်ဆိုတော့ပုံမှန်ပေးနေတဲ့လူတွေဟာဘာလို့ဆိုရင်ကိုရိုးဆိုလည်းဒီ ivermectin ကိုထူးပြီးတော့သုံးမှာမဟုတ်ဘူးလေအဲ့တော့ chronic diarrhea က strongylitis ဟုတ်တယ်ဒါပေမဲ့အမတို့ကတစ်ခုခုထူးပြီးပေးရမယ်ဆိုတော့ဒီI mean ပေါ့လွတ်သွားမလားပေါ့အဲ့ဒါပြောချင်တာပါဒါလောက်စူးစူးဝါးသူ့မြန်နိုင်ငံခြားတော့တောက်ခုရတယ်
ဟုတ်တယ်ဟုတ်ကဲ့ဒီ case ကတော်တော်လေး2 years လောက်ရှိပြီပေါ့နော်တမီးတို့လည်းသက်သက်ပြခြင်းမှာတော့လည်းဒီ chronic diarrhea case ဆိုတော့ case တိုင်းနီးပါးလာကတမီးတို့ albendazole ကတော့ပေးကြတယ်ပေါ့ဒီ case ကိုလည်းအဲ့လိုပဲပေးထားတယ်မှာပေးထားတယ်ဒါပေမဲ့ဒီသူကမရဘူးမှာဒီ albendazole နဲ့ကလေသူရနောက်တစ်ခုကတော့ auto infection ပေါ့နော်ဟုတ်ဒီ life တောက်လျှောက်ကို life long ကို patient ဟိုဟာထဲမှာနေနေရပေါ့မှာဟုတ်
သူရဲ့ 2R မှာလည်းတစ်ခါမှ strongyloides ရဲ့ X မတွေ့ဘူးပေါ့
မတွေ့ဘူးမှာစတူအာကြီးတွေအများကြီးပဲချိန်ပေါင်းများစွာလဲလုပ်ခဲ့တယ်
ထူးဆန်းတယ်
ဟုတ်တယ်မှာ literature မှာကလည်းအဲ့လိုပဲပြောတယ်မှာသူကဒီပုံမှန် 2R ကြီးမှာတွေ့ဖို့ chance ကအရန်ကိုနည်းတယ်ပေါ့နော်ရန်ကိုနည်းတယ် 30% လောက်တောင်သူမတွေ့နိုင်ဘူးပေါ့ frequent several specimen ယူရင်တော့တွေ့နိုင်တယ်ဆိုပြီးပြောတယ်မှာ
ဟုတ်ပါပြီချိန်လည်းမရှိရတဲ့အတွက်ကြောင့်
strongyloides ကနော်ဟို brain လာအဲ့ကြောင်သွားတယ်ပါယူသူပြောတယ် manifestation meningoencephalitis တွေပါရတယ် immune suppressed ဖြစ်လို့ရှိရင်ကျေးဇူးတင်ပါတယ်
ဟုတ်ကဲ့ပါ
thank you ပါအချိန်လည်းမရှိတော့လို့ပါနောက်ဆုံးတစ်ခုကတော့ဒေါက်တာဖြူဖြူစောနဲ့အဖွဲ့တင်ပြမှာပါ topic လေးကတော့ just for you မဟုတ်ပါဘူး just for sugar ပါနော်ဒေါက်တာဖြူဖြူစော please
သမီးတို့မိခွန်းနေမိထားတယ်အမှဖြေလိုက်နော်
share လို့မရအောင်ဆို post ဟော post က screen share လေး accept လုပ်
ရပြီလား
post က screen share လေးကူပေးလိုက်ပါဦးရပြီနော်
ဟုတ်ကဲ့
ရပြီရပြီရ
Good afternoon all. I am Dr. Juzo from Medical Unit 4 in Yangon General Hospital. Today I am going to be presenting about a case of acute abdominal pain. We got a referral from our surgical colleague concerning about very high blood sugar in a patient with acute abdomen. He is a 30-year-old obese gentleman with BMI of 35.6 kilogram per meter square. Further elaboration of his history regarding the abdominal pain, it is especially at the umbilical region and left iliac fossa, which is referred to PET. It is continuous and agonizing in nature, but he denied history of vomiting, fever with chills and rigors, and urinary symptoms, but his bowel opened normally. 6 months ago, he had a history of similar attack of abdominal pain, and so he went to GP and ultrasound was done and reported as colitis. And treatment was taken at the GP clinic accordingly, but at that time, no blood tests were done. 2 years ago, he had a gouty attack, and at that time, some investigation were done, and he consulted with the physician for high uric acid level and high triglyceride level up to 1,000, and he received some treatment. But he stopped all medications after 2 months because symptoms were improved. He had no history of hypertension, diabetes mellitus, ischemic heart disease, and stroke. He has never been hospitalized before. He is a non-alcoholic. He denied smoking and bitter chewing. He has a strong family history of diabetes mellitus in his father and elder brother, starting around about their age of 40. There was no family history of sudden cardiac attack in his family. He enjoyed fatty meat and soft drink. He used to drink at least 2 to 3 bottles of soft drink per day. He was not very keen to do exercise regularly. On examination, he was quite stable, apyrexia, no pella, no jaundice. His blood pressure was about 130 by 100 millimeter mercury. Tachycardia was present. Rate was 110 beats per minute and regular. Saturation is 97% on air. Heart and lungs are normal. Abdomen was soft and bowel sound is present. Slight tenderness is present at the umbilical region. These are the labs. There is a high blood sugar level of 303 milligram per deciliter and very high hemoglobin A1C level of 11.5%. ECG shows INS written and no STD changes. In terms of full blood count, there is a little bit polycythemia, but otherwise are unremarkable. In the renal panel, there is a hyponatremia, which may be the pseudo-hyponatremia because of the very high blood sugar level. In the liver panel, there is a slightly elevated liver enzyme, and that may be associated with fatty liver. Lipid panel is very interesting over here. We want to know his lipid panel because one thing, he had a diabetes mellitus, and the other thing is he had a history of high triglyceride level up to 1,000 2 years ago. And now his triglyceride level is pretty high, up to more than 2,500 milligram per deciliter. So we have requested the lipoprotein electrophoresis panel to find out the primary cause of hypertriglyceridemia, but results are pending.
And his lipase level is also increased for 20 times above the upper limit of normal. Corticalcium and albumin are within normal limit. Ultrasound abdomen reported as the acute pancreatitis and mild fatigue liver. And there is no evidence of gallstone and ascites. Physics will reveal normal. So the current problems in our patient is the newly diagnosed diabetes mellitus with very high RBS and very high blood sugar and hemoglobin A1C. And dyslipidemia, especially very high triglyceride level, lipid crisis with acute abdominal pain. Most probably the hypertriglyceridemia induced acute pancreatitis, and patient had morbid obesity. So treatments are given including antibiotics, pentosid, octreotide, and pain control. Our Medicare teams gave as the low molecular weight heparin 0.6 cc for BD for 7 days. And we started a variable rate of insulin infusion, not only for glucose control, but also for lowering the triglyceride level, followed by with a bolus insulin regime when the patient is already allowed. Patient discharged with the basal bolus insulin and pioglitazole, lipid triglyceride lowering therapy of fenofibrate. This slide is very important. This slide shows the triglyceride trending of our patient during hospitalization. In patients with hypertriglyceridemia induced acute pancreatitis, rate of reduction of triglyceride level is very important. In our patient, after giving of the insulin and heparin, our patient triglyceride level significantly and substantially decreasing from more than 2,500 up to 700 milligram per deciliter within a week. So our patient final diagnosis is hypertriglyceridemia induced acute pancreatitis with type 2 diabetes mellitus and morbid obesity. Let me continue literature review of the hypertriglyceridemia induced acute pancreatitis. It ranges from 2.3 to 10% of all cases of acute pancreatitis, especially occur in male and age less than 50 years. It is quite common in pregnancy due to their physiological changes. When serum triglyceride level more than 1,000 milligram per deciliter, it can be associated with the acute pancreatitis. The most important thing is that severity and complication rates of the hypertriglyceridemia induced acute pancreatitis tends to be greater than other causes of pancreatitis. Etiology can be divided into the primary and secondary causes as shown in my slide. Regarding the pathophysiology, increased serum triglyceride and increased serum chylomicrons can cause the increased serum free fatty acids, and these free fatty acids aggregate into the micellar structures that can damage to the platelets and vascular endothelium. This leads to the pancreatic islet cell ischemia, and that can create the acidic environment. The second thing is the increased plasma viscosity and capillary plating. That also leads to the pancreatic islet cell ischemia and acidosis. This ischemia and acidosis can cause the activation of trypsinogen, and finally, acute pancreatitis can occur. As a clinical presentation, at least 2 out of 3 of the following criteria are required for the diagnosis of acute pancreatitis, such as the characteristic abdominal pain, elevation of pancreatic enzyme amylase or lipase over 3 times the upper limit of normal, and radiological evidence of acute pancreatitis. Our patient complete these 3 features. Serum amylase level at presentation could be normal due to the calorimetric interference of the lipemic serum. Serum triglyceride level should be measured as soon as symptoms started, because triglyceride level rapidly trend down with fasting. And we also find out the other chronic hyperlipidemic features, such as the eruptive xanthomas over the extensor surface, cornea arcus, and lipemia latinalis. These are the management. Firstly, we give the conservative management, including the bowel rest, IV fluid therapy, and pain control. Second one is insulin and heparin therapy. Insulin therapy can lower the triglyceride level up to 50 to 75% over 2 to 3 days by means of activating the lipoprotein lipase activity, which accelerates the chylomicron degradation, and it can also rest the pancreatic tissue. We can give the continuous IV insulin infusion of regular human insulin at a rate of 0.1 to 0.3 unit per kg per hour to maintain the triglyceride level less than 5.6 millimole per liter. Dextrose infusion is titrated to avoid hypoglycemia, and we want to maintain the blood sugar level between 120 to 200 milligram per deciliter. Serum triglyceride level should be monitored every 12 to 24 hours. heparin therapy. It can lower the triglyceride level by releasing the stored lipoprotein lipase from endothelial cell. But one important thing we should notice is that rebound hypertriglyceridemia can occur due to the long-term or continuous heparin infusion causing to deplete lipoprotein lipase, leading to reduction of chylomicron catabolism and increase in triglyceride level. We can give the SE unfractionated heparin or low molecular weight heparin, but continuous heparin infusion is better avoided due to risk of hemorrhage into the pancreas during the acute attack. Third one is plasmapheresis. It can improve the pancreatitis by means of removing the triglyceride and chylomicron from circulation, can also remove the pro-inflammatory markers and cytokines to downregulate the inflammatory response. It can rapidly remove the triglyceride and chylomicron from the circulation, so it can alter the further inflammation and damage to the pancreas. We can be used in the treatment of patient failing conservative treatment. Okay. As a long-term management, once the patient can tolerate the oral intake, adjunctive lipid lowering therapy should be started, low-fat diet is needed, and lifestyle changes is important. So fibrates are the most effective in lowering triglyceride level. Omega-3 fatty acids are reasonable second choice. Niacin and statins can be added. Novel pharmacological treatments are developing for severe hypertriglyceridemia now. This is the end of my presentation. Thank you.
ဟုတ်ပါပြီဆီယမတို့ team ကိုလည်းဒီလိုရှာရှာပါပါ triglyceride level ထောင်ကနန်းကြည့်ပြီးတော့ acute pancreatitis ဖြစ်သွားတဲ့ဟာကိုရှာရှာပါပါတွေ့ရတယ်ဒါလေးအောင်မြင်ကုနိုင်လို့ congratulation ပါ question လေးတစ်ခုလောက်ပဲမေးလို့ရပါမယ်အချိန်လွန်နေပါပြီ Q&A session မှာပါတဲ့ question လေးတော့တမိပြည့်ဖြေပေးလိုက်ပါ If I have to conclude this session I think we all enjoy all the interesting cases. First case about pandemic in the COVID pandemic era, pregnancy, complication, DIC. And second case, the beauty of nephrology in view of diabetic nephropathy. And third and fourth case from cardiology. And the fifth case from the neglected tropical disease thrombolysis. And the last case, acute pancreatitis caused by severe hypertriglyceridemia. Finally, I would like to say thank you to academic committee of MMA and all the presenters, and finally to all the audience. Thank you. Very good evening. Thank you.
အားလုံးကျေးဇူးတင်ပါတယ်6နာရီထိုးဖို့15မှာဒီစုဝေးပွဲအစီအစဉ်ကိုပြန်ကြည့်ဖို့ပြန်ပြီး join ဖို့ဖိတ်ခေါ်ပါတယ်ဒီခုလောလောဆယ် session ကတော့7 minute refractory လုပ်ပြီးလို့ရှိရင်ကျမတို့ OG ကို hand over လုပ်ပါအားလုံးကျေးဇူးတင်ပါတယ်
ကျေးဇူးတင်ပါတယ်နော် Thank you